We started this study because locally advanced pancreatic cancer represents 30 to 35% of all pancreatic cancers, and it's a condition that we really don't know how to optimally treat. There's been very few studies that have really made major progress in locally advanced pancreatic cancer, and the median survival has ranged somewhere between 9 and 19 months across several prospective studies. And the modern systemic therapy regimens of FOLFIRINOX and nab-paclitaxel are used routinely in locally advanced pancreatic cancer, even though there's really only been one prospective study with either of those regimens. That's the LAPC study with nab-paclitaxel. And about 10 to 15% of patients do get rendered operable, but the vast majority of patients remain incurable. And while most of us will incorporate systemic therapy, we really don't know. We would like to be able to incorporate local therapy as well, but that's been very controversial. In fact, radiation therapy for locally advanced pancreatic cancer, even though many of us use it, has never been proven to be a benefit for that disease. So part of the reason that we wanted to go through this intra-arterial approach is really based on the scientific premise that's been well established that pancreatic tumors, particularly the primary tumor in the pancreas, is notoriously resistant to chemotherapy, in part because the chemotherapy doesn't get delivered very effectively to the cancer cells. The tumor is very dense, has a very fibrotic stroma. It's actually very minimally cellular, but also there's a high degree of interstitial pressure. And so the chemotherapy that's given intravenously doesn't actually get very effectively to the tumor. So this tissue microperfusion system was developed to try and increase the concentration of chemotherapy within the local tumor microenvironment, and has been shown in early studies and preclinical models to increase the concentration of, in this case, gemcitabine locally to the area of the tumor by about 100-fold. We wanted to design the study to do two things. One is to kind of cut through some of the controversies. And I mentioned the controversy about the role of radiation therapy, the controversy about which systemic chemotherapy regimen to use, and the controversy about how long to continue chemotherapy. And so one of the ways we thought that would circumvent those problems is really to go for a gold standard endpoint of overall survival. So all of these other issues and how we chose to pursue the study again, have some degree of controversy, but at the end of the day, we're asking a fairly simple question, which is, does the addition of intra-arterial gemcitabine instead of continuation of the IV gem-nab-pac improve overall survival for these patients? So the study design was a randomized phase 3 trial. It had a power of 80% to detect a hazard ratio of 0.06. And with that study design, 114 patients would ultimately need to be randomized to detect and the improved overall survival. But we also designed the study in a very kind of real world way, meaning that we know that local therapies generally are being used after a period of systemic chemotherapy now. And so the way the study is designed is patients get started on induction gemcitabine nab-paclitaxel, completely standard of care. In fact, actually, we allowed patients to start gem nab-paclitaxel outside prior to enrollment, and then they would still be eligible if they came to a study center to join the study, because many times patients will see us for a second opinion after they've already started treatment. So we've allowed them to start the gem nab-paclitaxel and then enroll in the study. So they get an induction period of chemotherapy, systemic chemotherapy with the gem nab-paclitaxel. We also added in, during the induction phase, radiation therapy, specifically SBRT, stereotactic body radiotherapy. And the reason for that is not to kind of dive deep into the controversy about the role of radiation, but it's actually based on the observation in the original registry study done with this tissue microperfusion system, that the patients who got radiation therapy prior to getting the intra-arterial gemcitabine had a significantly longer overall survival. And in some of the preclinical models, this is really borne out with the science, because essentially what happens is this intra-arterial gemcitabine is injected into the artery most proximal to the tumor, and we're anticipating that it diffuses, or that there's a higher concentration that's getting to the tumor. Some of that gemcitabine will leak off into the vasa vasorum, the small little blood vessels that actually feed the artery itself. And the radiation therapy actually damages those vasa vasorum, and thus really focusing the gemcitabine to get just primarily to the tumor. So during induction, patients also get SBRT. After 4 total months of induction, patients are then enter the randomization phase, where they get randomized to either get continuation of IV gemcitabine nab-paclitaxel for 4 months, standard of care dosing, or they get 4 months of, or up to 4 months of intra-arterial gemcitabine, which is given intra-arterially once every 2 weeks for a total of up to 8 treatments. That 4 months is really the study period, the randomization period. After that period, if patients continue to have non-progressive disease, they then go on to continuation therapy. And we gave, again, making it kind of real world appropriate, we gave physicians the choice to either continue the IV gem nab-pac or to move on to maintenance capecitabine, which is what I tend to do. So it was sort of my influence in that study. And then we ultimately follow the patients for overall survival. So again, the study needs 114 patients ultimately to be randomized, but the FDA allowed for 2 interim analyses, and this report was the first interim analysis where 26 events had occurred, in this case, events being death or withdrawal from the study for any reason. And at the point of the first interim analysis where these 26 events had occurred, 45 patients total had been randomized in this study. So this was a true locally advanced patient population, locally advanced by NCCN guidelines, which are now considered kind of the gold standard across the world. And what we found at the first interim analysis was, first of all, that actually, to my surprise, to be perfectly frank, the period of randomization to intra-arterial gemcitabine was actually better tolerated. When you look at all adverse events, the rate of adverse events was 65% lower for patients who received intra-arterial gemcitabine. And when you really break it down by each individual adverse event, the intra-arterial gemcitabine group tolerated things better for the most part, with the exception of abdominal pain and nausea, which tended to be transient, better than the continuation IV gem nab-pac. In terms of the hard outcome of survival at this first interim analysis, we were very pleased to see that there was an improvement in overall survival. So the median overall survival for patients who were randomized to the the intra-arterial gemcitabine arm was 15.7 months, compared to 10 months roughly for the patients who were continuation of IV gem nab-pac. And then similarly, the progression-free survival was also greater. It was about 14.5 months for the IA gemcitabine versus only about 7.6 months for the IV gem nab-pac. Now, these numbers don't sound great, but actually it really has to take into consideration that we're counting the clock from the period of randomization. And on average, across the groups, the patients who get to the point of randomization were in the induction phase 5.5 months from the time of diagnosis. So really, when you look at it from the time of diagnosis, the overall survival for the IV gem nab-pac arm was about 15.5 months, which is right in line with previous prospective studies. But the intra-arterial gemcitabine arm was 21.5 months, which is about 6 months longer. Well, I definitely will be very clear that this is just a first interim analysis, and I'm holding my breath. I would love for this to be a positive study, just to have another option for patients. But I also know the nature of pancreas cancer trials and how many of them started as promising phase 1 or phase 2 studies, ended up being negative phase 3 studies. So this is a little bit different. It's an interim analysis of a phase 3 study, but nevertheless, we really have to wait for the final results to come out. We are expecting the second interim analysis in late 2024 and the final study to be reported out in 2025. If this holds true, if the current overall survival benefit holds true, I think that it really, it would definitely open up an option for patients to incorporate this into the treatment for their pancreatic cancer. I think the observation, and we actually are doing a bunch of healthcare related quality of life assessments. If the observation that the adverse events are less, that the patients actually tolerate it better, then it really paints a picture where patients basically get a break from chemotherapy, from ongoing weekly, 3 weeks on, 1 week off IV gem nab-pac, and instead can get this period where they're just getting the once every 2 weeks procedure. It is a procedure that has to be done in the interventional radiology suite, but It seems like patients actually are tolerating it pretty well. So that's one nice thing. It gives them this break off of systemic chemotherapy. The other thing is it opens the door. A lot of people have asked us about what about other chemotherapeutic agents that could be delivered intra-arterially, and certainly there are things that are being there are drugs that are being investigated in addition to gemcitabine to be used intra-arterially. And of course, with the NAPOLI-3 study, we can have a whole separate discussion of how to interpret that data. But I think one of the interpretations that's perfectly reasonable, and Dr. O'Reilly actually said this clearly in her recent ASCO presentation, whatever the debate of whether we should be using nanoliposomal irinotecan or not, one thing that's clear is that 3-drug chemotherapy has now been shown to be better than 2-drug chemotherapy, i.e. NALIRIFOX is better than Gem-Nab-Pac. And so with that foundation, it opens up the door to saying, okay, if this intra-arterial gemcitabine paradigm proves if the overall survival holds true, then we really should also be testing this in the context of a FOLFIRINOX-based regimen, which actually really is a regimen that needs a break. I've treated many patients with IV Gem-Nab-Pac and don't really mind continuing it on an ongoing basis, but you can't give patients FOLFIRINOX for more than about 4 to 6 months without really needing to drop the doses, change the schedule, something along those lines. So to have a period of a respite with 4 months of IE gemcitabine would be a real pleasure to incorporate into the treatment of locally advanced pancreatic cancer for patients treated with FOLFIRINOX. But of course, that would probably something that needs to be established in its own independent study.